Welcome to this presentation hosted by the International Center for Moral Injury here at Durham University. As with much work on moral injury, this presentation does deal with a difficult topic. If you're affected by any of the issues discussed, please do see the video description for sources of support. So, without further ado, let me turn to introduce our speaker for this evening. Dr. Colette Hawkins worked as a consultant in palliative medicine in Northeast England for 16 years. 8 years ago, she moved from a clinical role to an academic one in order to generate space to research the reality of life when living with progressive or serious ill health. In that capacity, she's developing and delivering creative education for more honest and person-focused care. And so I'm honored tonight to welcome Colette, and will now turn things over to her.
So thank you very much for that welcome, Brian. It's great to be here, and I've really enjoyed the conference back in April now with lots of really interesting discussions. So I'm keen to know what this elicits in terms of conversation. Brian's already given me a little bit of an introduction, but so I live and work in Northeast England. I live in the beautiful city of Durham, and I just thought I'd raise awareness of palliative care because I guess not everybody will be very familiar with what that is. So palliative care is defined by the World Health Organization as an approach, and that it's intended to improve the quality of life of patients, whatever age, and their families who are facing problems associated with life-threatening illness. The intention is to prevent and relieve suffering, and that's an important word that I'm going to come back to, through identification, assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. But some people like me specialise in palliative care, but it's really important to note that palliative and end-of-life care are relevant to the whole health and social care workforce. And most people who are approaching end of life don't see specialist palliative care services at all. So that's just by way of preamble. In terms of what I want to cover, I want to talk about medicalisation, what it is and why it may be happening. I want to then talk about, wrapped in with that, the consequences, and I want to suggest that we may be morally injuring the public. Controversial, possibly. We'll see what you think. I think there's a gap, and my suggestion with that is that we need to think about suffering, and we also have a gap with spirituality. And we're then going to talk about the physician perspective. I want to think about whether we are morally injuring ourselves as healthcare providers because of the way we approach end-of-life care. And finally, where do we go from here? And just a note about my perspective, I come at this as a doctor, and I can really only speak from that perspective. So that's the angle I'm bringing. Other people in the audience may have perspectives that can complement that. So Brian, this is pinched from your webinar and obviously from the website. This is the definition of moral injury from the ICMI website, describing moral injury as the experience of sustained and enduring negative emotions, which may be guilt, shame, contempt, or anger, resulting from the betrayal, violation, or suppression of deeply held or shared moral values. I think that's an important thing about what it is, but this definition from Shea, or this description from Shea, talks about the context where moral injury can happen. And it talks about moral injury being present when there has been a betrayal of what's right by someone who holds legitimate authority in a high-stakes situation. And I'm hoping that by the end of my presentation, you'll have a sense that I feel this is fairly central to what we're talking about in healthcare. So I want to talk about medicalisation. And what do I mean by medicalisation? Well, in a simple form, medicalisation is when aspects of human life become medical problems. And somebody has described it as when moral, social or legal problems become medical issues. And how do we know that that's happening in end-of-life care? Because there is evidence that it is. Well, we know that death is happening more often in hospitals than in homes. There is an increasing use of futile or inappropriate medical treatment near death, and families and communities are less involved than they used to be. There's a really interesting paper commissioned by the Lancet Commission called The Value of Death. And if anybody's interested in understanding a little bit more about cultural contexts and some of the things that I'm talking about, including going into health economics, then it's a really good overview. I'm wanting to focus more specifically on one aspect of medicalisation, which is called overuse. And overuse of medical services is defined as when medical services are more likely to cause harm than good. And it's known to be a pervasive problem in high-income countries. We know that it can cause physical and psychosocial harm to people and harm health systems by wasting resources and diverting money that could be spent elsewhere. Now, this is the only data I want to show you. This is an old set of data from 2014, but I don't think anything has changed except for the cost. So what this shows is average hospital costs per day over the final 90 days of life. And you've got on the y-axis, you've got cost per person, cost of care per day per person in pounds. And along the x-axis, you've got days prior to death. And what you can see from the graph is that when you get to about 30 days before death, there is an exponential rise in cost of care. And that is driven very significantly by emergency inpatient care. So what this tells us is that we are admitting people very close to the end of their life. There is data around health expenditure, which shows that in high-income countries, between about 8 and 11% of annual health expenditure for the whole population is spent on less than 1% of people who will die in that year. And if you look at the last 3 months rather than the last year of life, it can be closer to 20%. So this is expensive. Now, does that necessarily mean it's a bad thing? Well, of course, not at all. And if this is doing something that's useful for people, then absolutely, that seems fair enough. And it just is expensive. The problem is that we are in a situation where people are unprepared. We're not having conversations. They are not given choice. And what that means is that when crises happen, which are inevitable as people get closer towards dying, there will be an emergency response, a sort of algorithmic knee-jerk reflex of calling an ambulance and admitting into hospital. And that may well not be either what people want or what people need. So we need to take a long, hard look at how we are approaching people who are dying. One of the things that I did when I sidestepped from clinical work was to look at the way we teach and learn around healthcare, and particularly around end-of-life care. And the first piece of work that I did was to do a project collecting stories from people on the receiving end of care, but also professional providers of care. We're very good in clinical services at sanitizing things. So we talk about patient AH who had a liver cancer or whatever, and there is nothing about that person in that description. So we use stories now, and this is part of the way that I support learning, and they become springboards for discussion about what matters to people, why things are difficult, where the barriers and the opportunities lie to do things better. One of the stories was provided by a lady called Ellie, who may be on the call, and she wanted to share the story of her mum. Ellie was working as a nurse at the time, and she felt it was important that health professionals understood her experience with her mum. So I'm going to show you this story now. It is a powerful story, hoping that it runs okay.
I was with my mum, waiting to see the consultant. My mum, the psychiatric nurse. But she was frightened. The lung cancer specialist nurse slithered into the room just ahead of us. Oh shit, I thought, this is not good. The registrar gave my mum the bad news, which she handled very well, with compassion. Mum had lung cancer, and it had already spread to her ribs, but I knew in that instant it had also spread to her brain. My mum, the communicator, was having difficulty communicating. We were plunged into a whirlpool of investigations intended to find out exactly what kind of lung cancer Mum had, so they could treat it appropriately. This drove them. I knew it was futile. Mum knew it was futile. The brain mets were the enemy, and we were past treatment. She needed symptom control and palliative care. She was labelled a lung cancer patient, and the consultant was keeping hold of her. No one ever asked my mum what she wanted, yet she knew what was wrong with her, and she was the expert on herself. No one ever asked me either, yet I was a palliative care nurse. And in the middle of the madness and the maelstrom of investigations, we went home, and it was then she said, "All hope's gone." My mum, dynamic, full of life, hilariously funny, astute and a coper. My mum taught me the importance of listening to patients and picking out what was important to them, yet nobody bothered to do that for her. I felt completely helpless and hopeless. I knew what was coming, and it would be horrendous. Valuable time was lost because they didn't listen to us. They didn't even ask us. Her main problem was back pain, but they did nothing about that. They just followed the plan. She died 7 weeks after diagnosis, in pain. She had terminal agitation from the brain mets and was tormented by a fractured spine. Thank God for the hospice who helped me care for her. If anyone had asked my mum what she wanted, if anyone had listened to her answers, if anyone had ever seen her as a whole person, the outcome would have been the same, but the journey may have been very different.
So I'm very grateful to Ellie for sharing her story, and we use this a lot for for supporting education, particularly of doctors. And just reflecting back to the definition of moral injury that I put at the beginning, I've got a question about the definition, and I think there's some interesting conversation to be had around language and what we understand about moral injury, because I wonder what sustained and enduring mean when we're talking about people who are towards end of life. And I think that it's possible that Ellie's mum was morally injured by the way that she was treated in ways that didn't match what mattered to her. But she didn't live very long. But the other thing I think that's really important to say is that when we're looking after people towards end of life, the people around that person are very much at risk from the consequences of the way we approach care. So I feel that Ellie may have been morally injured as a consequence of her mum's treatment. And this is not an unusual story. So just to summarise really on medicalisation of death, we know from reports that we increase suffering by our approach to end-of-life care. And the reasons for that are around failure to recognise people as dying or close to dying or potentially end of life, and sometimes we get that wrong, offering traumatic and or futile treatments, generating false hope, depersonalising people, turning them into a disease rather than a person with hopes, wishes, ambitions, things that matter to them, excluding family and carers, relegating them to the margins, and in all of that, actually managing to miss some of the physical symptoms that people struggle with because we're so focused on, as Ellie's story said, following a plan. So why are we doing this? I've given you a lot of reasons to suggest that this may not be actually the right approach for at least some of the people we're looking after. So what's driving that? Well, I think there are various reasons, and I've got these three here, which I mentioned at the conference, and these have been mentioned in a number of different reports, that doctors are trained to fix. We have a problem, our job is to solve it. There is this thing about demand for treatment. I think there's a bit of a chicken and egg with that, because actually we're so culturally used now to medicalisation that we have become very underconfident at managing people dying at home. So I think people do expect to have specialists and healthcare services swoop in and take control of situations. But the other reason is that because we got increasingly complex and technologically advanced treatment options available to people. And that generates challenges in terms of how we make decisions. Just because we've got the technology doesn't mean it's necessarily right. But there's another one that I want to add to that, which I'll come back to, which I call the professional as a person. And this is about, what is it about me as a person with a professional badge that feeds into this dialogue and experience and outcomes of the consultation? Because I feel quite strongly that this is underplayed, but very important. So I'll come back to that. And I think this fix-it mentality that comes out of medical school is very much around this war with death. Again, I showed this in the conference. This is Asclepius with his rod of healing. And it's interesting that they call it a rod of healing, because he's focused on defeating death, which of course he's never going to win at. And that is where we're managing to put our attention as medical staff. And that generates this code for doctors. And that's at odds with what people, if you ask the public what they would view as a good death, they talk about very different things. And this is the sort of thing that comes up from the literature. People want to have choice. They want to be pain-free and free of other symptoms as well. And then there's this hodgepodge about emotional well-being. There's a whole load of things in here. Things like tying loose ends, restoring relationships, getting to grips with what value has my life had, what does it all mean, where am I going, all these existential questions. And moving on from that, Marie Curie has defined a good death about ensuring comfort, dignity, and alignment with personal wishes, whilst respecting clinical, cultural, and ethical standards. So you can see that this very narrow-minded medicalization is really missing a whole load of things that are actually important to people. I want to just build on that with mentioning a patient called Joseph Lazaroff. And this is a reflection by an American surgeon called Atul Gawande, and you'll hear more of him later. And anybody who knows me knows that Atul Gawande is my hero. He's a very reflective surgeon, and he looks back and questions himself and questions what we're doing in, I think, a really helpful way. And he reflects back to when he was a junior doctor and involved in the care of this man called Joseph Lazaroff, who was a man in his 60s with advanced prostate cancer, which had spread throughout his body, including his spine, leaving him with pressure on his spinal cord and inability to use one of his legs and loss of control of his bowels. And Atul Gawande, as a junior doctor, was tasked with taking consent from him for his treatment, and he was given the option of neurosurgery, which was a complex and risky procedure, or no active treatment. And Joseph chose to have the neurosurgery. He had 8.5 hours of surgery, which was technically a success. He went from theatre into intensive care, from where he never left. He died within a couple of weeks of multi-organ failure, having never recovered. And Atul Gawande reflects back on this and describes, we could never bring ourselves to discuss the larger truth about his condition or the ultimate limits of our capabilities, let alone what might matter most to him as he neared the end of his life. And he goes on to say the chances that he could return to anything like the life he had even a few weeks earlier were zero. But admitting this and helping him cope with it seemed beyond us. We offered no acknowledgement or comfort or guidance. We just had another treatment he could undergo. There was a big study in the US called the Support Study, which looked at care of people who are dying. And they summarized their findings as people who are dying as caught up in a medical juggernaut, driven by a logic of its own, one less focused on human suffering and dignity than on the struggle to maintain vital functions. This lady, Nancy Jecker, sort of, she wants to say her piece, and I think this is, she doesn't hold back. So this is what she says in a piece that she wrote called The Problem with Rescue Medicine. She says, one is trying something, but it is not rescue. And this is relating to that fix-it mentality. A more honest telling might be harming the patient, wasting resources, feeding false hope, disregarding professional standards, failing to show courage, being seduced by technology, neglecting to focus on palliative care, being co-opted by the family, refusing to acknowledge medicine's limits, denying a patient's impending death. And she goes on to say that characterizing the use of futile interventions as rescue or attempted rescue clouds our moral perception, making it difficult to identify the morally egregious features of what we are doing. So she really doesn't hold back with that. And I think it's really valuable that we take stock and think about whether what we're doing is right. But I guess the question, bringing it back to the context of the webinar, is, does this amount to moral injury? And for me, I think that it may well do. And going back to Shay's definition, for me, it fits very much with this description. So I said that I was going to talk about a gap, and that's what I'm going to do next. Just very briefly, and I'm not going to expand on this, but just to emphasize the problem that we generate by focusing really solely on physical disease. Marie Curie last year published this report, Dying in Poverty, which shows that approximately 1 in 6 adults in the UK die in poverty. And that goes up to roughly 1 in 4 adults of working age. And the reasons for that are a combination of the fact that it is expensive to live with chronic ill health, particularly towards end of life, and people lose income. And particularly if you're of working age, you're more likely to lose income and you're more likely to have additional costs with dependent children. What we find with people who are facing end of life is that these issues cause massive problems for them. And whilst they're busy trying to attend hospital appointments and manage treatment plans, they're coping with the fact they can't afford the heating and other things like that. And it's something, this is part of my research and trying to help healthcare professionals recognize that if we miss this, we fail to support people in ways that matter to them. And that impacts on their health and it impacts on their ability to engage with treatments. So that's just one bit of missing things. But the other thing I want to talk about is suffering. This is a fictional story written by Leo Tolstoy called The Death of Ivan Illich, and it was written in the late 1880s. And it tells the story of this guy called Ivan Illich, who was a High Court judge in his community. And he had an accident. He, I think, was climbing a ladder and had a fall, had terrible pain in his side, which just wouldn't go away, and in fact just got worse and worse. And he consulted with doctors and he tried all sorts of things, and nothing seemed to improve it. And the description around what his experience was describes his suffering. Tolstoy writes, what tormented Ivan Illich the most was the deception, the lie, which for some reason they all accepted, that he was not dying but was simply ill, and he only need keep quiet and keep going with treatment. But as Ivan grows weaker and starts to get emaciated, he knows what's happening to him, and he lives in mounting anguish and fear of death. But nobody's willing to talk to him about what he thinks is happening to him. Death is not a subject that any of them are willing to talk about. And the description goes on that at certain moments when he's really suffering, what he longs for the most is to be cared for like a sick child. And he feels almost guilty about that because this is a High Court judge with a greying beard and he wants to be comforted, but he feels that that's impossible. So I think we miss suffering. And I think this quote is fantastic. Man is not destroyed by suffering. He's destroyed by suffering without meaning. And Eric Cassell in The Nature of Suffering and the Goals of Medicine sort of inserts that into the context of healthcare and says that suffering is experienced by persons, not merely by bodies, and has its source in challenges that threaten the whole of us as a person, as a complex social and psychological entity. But as physicians, if we fail to understand the nature of suffering, what we then end up doing is giving medical interventions that, although they may be technically adequate, not only fail to relieve suffering, but become a source of suffering in and of themselves. And that's exactly what Ellie describes in her story, and Atal Gawande describes in Joseph Lazaroff. And I think one of the issues around suffering is that we don't engage with spiritual care around end of life. And what we know is that spiritual care is the most neglected dimension of palliative care. And if you remember back to what I said about the World Health Organization, spiritual care, spiritual issues are part and parcel of how we should approach palliative care, because people have physical, spiritual, psychological, and social components to them. All of us do. But we know that it's the most neglected dimension. Why is that? Well, there are probably a lot of reasons, but some people think that there's confusion between what's spirituality, what's religion, this thing that people are labeling conceptual muddiness, and staff feeling I'm a healthcare professional, I shouldn't really be talking about religion. I don't feel comfortable with that. There's lack of confidence. People don't want to raise questions because they're worrying whether they're treading onto ground that they shouldn't be treading. And also, fix it and solve. Where does spiritual care fit into that? Well, it really doesn't. But I think going back to the concept of professional as a person, speaking for myself, I think it's really important that we recognize that we bring ourselves, and we need to consider how comfortable am I as a care provider with our own spirituality, recognizing that we bring our views and our biases and our prejudices into those consultations. But this gives us an opportunity for improvement, because I think some of this is actually relatively straightforward to address. I think helping people to reconnect with the human, even if that's just helping people with a really simple foundation question for opening a conversation about spirituality and giving professionals permission to do that, recognizing that is part of their role, I think would make a big difference. So this is the last bit about the famous Atal Gawande that I want to mention, and I want to show you a very brief YouTube video which describes his own experience of his dad's ill health, and again reflecting back on his experience of the healthcare professional approach to it. So I hope this runs okay. Shout if it doesn't.
One of the reasons I write is it gives me my chance to dive into problems that I'm very confused about. I've written about, what are we supposed to do about the cost of healthcare? Why is the malpractice system so crazy, and what's the way it should be? I've written about why do we itch? If it's confusing and interesting to me, writing is my way of diving in and figuring out what to at least think about it. And this was one of the big ones. The two big unfixables are aging and dying. You can't fix those. We're afraid of talking to the patient about these problems as well. A lot of doctors feel like, I know how to have this conversation. I know exactly what I'm doing. But what I could see over and over again was that we weren't particularly good at handling people going through the last phase of their life. I've had to learn that because of patients with whom, they did not end up with a good experience at all. And then I've had to learn it the hard way because of my dad. Do you remember when Dad first started to get pain in his neck?
He thought either playing too much tennis or just muscle.
And instead what they found was a tumor, a huge tumor. I remember I took notes in my journal around that time. This is my dad saying, the way things are going, I could be bedridden in a few months. The tumor had extended into his midbrain. The suggestion was that we should go see what options there might be for chemotherapy. So the oncologist lays out 8 or 9 different options, and we're swimming in all of it. Temozolomide, vincristine, vinblastine. And my dad says, well, what if I don't take any? And she said, well, that's your choice. Then started talking about how, you really should think about taking the chemotherapy. Who knows? You could be playing tennis by the end of the summer. I mean, that was crazy. It made me very mad because it was,
completely not right, yeah.
You know, this guy's potentially within weeks of being paralyzed. It was holding out a hope that was not a realistic hope in order to get him to take the chemotherapy.
When he made the final decision that he doesn't, want to, I told him, for me it's okay if you're paralyzed, so what? I can take care of you. Yeah. And that's the main difference. It was not fine for him.
The oncologist was being totally human, and the oncologist was talking to my dad the way that I have been talking to my patients for 10 years. But hope is not a plan. And in fact, we find from our trials that we are literally inflicting therapies on people that shorten their lives and increase their suffering out of an inability to come to good decisions.
So just to build on that reflection on a medical approach and what it's like being the doctor helping people make those decisions. This was a study done in America, California, and this may be a relatively small and potentially self-selected sample, but they found out of 454 clinicians, 40% of those interviewed fitted the definition of clinical depression. Most reported that they thought about leaving the profession at least once in the last 12 months. And they talked about burnout, and that's something that the language, we might need to think about the language, but they related burnout to destruction of personal meaning for physicians concerning the care that they deliver. And this piece, Recapturing the Soul of Medicine, goes on a little bit further and looks at the fact that there's an unprecedented number of physicians nationwide, that's the US, many of them young, dropping out or seeking early retirement. Something unusual is happening among physicians, and those who care about physician well-being may need to broaden their concern from the care of impaired physicians to the care of all physicians. The future of our profession may be at stake. And I just want to finish, or close to finishing, with a story of my own. This is me, fresh-faced, a year out of medical school, heading into my second year junior hospital job at Stoke Mandeville Hospital in the south of England. And I joined a gastroenterology team there. We had a patient who was an elderly lady who had nutritional problems and had become very emaciated. So she was elderly and very frail. And a decision was made that she should have feeding artificially provided through directly into her vein. And in order to do that, she needed what's called a central line. And this is a wide bore cannula, which goes directly into a vein in the neck. And through that, liquid nutrition is provided. Now, at that point in my career, I was at the stage where it was a question of, yeah, you need to learn this procedure. I'd seen a few. And so I was tasked with doing this. But because I hadn't done one before, my immediate senior, the registrar on the team, was right beside me, talking me through shoulder to shoulder, and we did the procedure, which seemed to go okay. We finished with a chest x-ray, which is a standard procedure. And when we looked at the chest x-ray, we could see that the feeding tube was too far in. And it was sitting, the end of it was sitting in her heart. Now that is not in itself necessarily a bad thing, you just pull it back. So we pulled it back. What we didn't do is re-x-ray. That was at the end of a working day, and the next day I came in and was met with the news that she had died overnight, and that made me very uneasy. We then went on the consultant ward round, and without warning, the ward round went via the mortuary. And the pathologist was partway through a post-mortem for this lady. And we were just through the doors when the pathologist sort of called over with a slightly sarcastic voice saying, I think I've found the cause of death. And he was holding her heart in an open chest with the feeding tube coming out of it. And I don't think I can give in words how it felt at that moment, except that the ground shifted. And I was completely incapacitated. The consultant, seeing that I was horrified, came across to me, and his pastoral care, as far as I can see, was, "You don't feel guilty, do you?" That was it, which actually made me even more horrified. I was given a week or two off work, which I had to take because I couldn't really function, during which I found myself another job outside healthcare. I obviously didn't take it in the end, but I was very tempted. And when I came back, I had to go to the coroner's court for the inquest, unsupported. None of the team came to support me, in which I was quizzed by the family and their representative about exactly what had gone wrong. It was deeply traumatizing, and looking at the definition of moral injury, I feel pretty much that I was in that definition. And it took a lot to come to terms with that, really. That was a long time ago, but interestingly, my daughter, who's at university, was recently with a group of junior medical students who were explaining that their lecturer had decided that they wouldn't give the seminar that was planned, but they would go to the mortuary instead because it was about time they learned to see dead bodies. And I think we need to take a very long, hard look at how we teach medicine and how we support medical staff and healthcare staff more broadly. Now, the flip side of all of this is that it's made me very passionate about what I call the professional as a person, and the fact that being in healthcare, particularly in a medical role, things will go wrong, and things will go wrong in our hands. And that is a very difficult thing to come to terms with, and it's something that we have to be more honest about. So this is something that I feel increasingly comfortable with putting out there, my honest experience, how it's left me feeling, and how I think that we need to support each other as we train and support medical staff into medicine and beyond. So a challenge and an opportunity. So just to finish off, I think there are points for improvement. I think we have the opportunity to see people as a whole. After all, that's what we're meant to be doing. I think we need to recognise that suffering is inevitable, and physical treatment is not going to fix that, and on its own it's not going to be enough. There's a real opportunity to build self-awareness in clinician, in health professional training and the ongoing pastoral support. We need to be thinking, what is about me that is influencing how this interaction's going, or the decisions that are being made? What's motivating me? What's driving me? What are my values? What are my views of death? What it all means? We need to be better at being alongside suffering and being willing to support people spiritually. Basic questions may be enough to help that. And we really need to be finding ways to support people pastorally in health settings. So finally, where do we go? Well, I think there's a real opportunity with language. I think we need to start talking about moral injury, because I think the more we look, the more we find. And I think it would be really useful to start making this part of core discussion in health professions. I think that would be very helpful. There's real opportunity with both education and research. I feel that this is something that I'm actually already doing to some extent without realizing, and I think there's real opportunities to build on that. And if anybody's interested in taking that forwards, feel free to get in touch. This is something that I would really love to develop further. So with all of that said, thank you very much for listening. I'd be really interested to hear what you've got to say. And anybody who wants to get in touch after this, feel free to drop me an email. Thank you very much.
Thank you so much, Colette. I think there's so much there that's wonderful for us to think about, and I think you brought to light and for us to consider.